Good evening, friends. So this week we bring you a new specialty, not very new, but now intervention in musculoskeletal ultrasound are increasing. So we have with us Dr. Gaurav Vashishth, who's an expert and a consultant in musculoskeletal radiology, as well as he does interventions. I would request him to tell us family physicians when to use musculoskeletal ultrasound, and more importantly, what interventions can be done where we can refer our patient to such experts. I have used here musculoskeletal ultrasound mainly for ankle pain where I wanted to do MRI, but the patients came back because they couldn't withstand the sound, and they were claustrophobic. But otherwise, there are a lot of indications where musculoskeletal ultrasound wins over even MRI. So, Dr. Gaurav Vashishth, over to you.
Good evening, friends. Thank you so much, Dr. Asrani, for giving me this opportunity to speak on this topic, which is not new now. But then a lot of our colleagues are unaware of a lot of things regarding the musculoskeletal radiology and interventions. So I thought I will try to make this topic a little practical in terms of how we deal patients in our daily practice, not just getting a high standard MRI done, but with basic modalities like ultrasound and radiographs, we can make appropriate diagnosis. Thank you once again for joining us, for joining for this lecture. So I will, without taking further time, I will begin with the talk. So, MSK radiology means muscle plus skeletal plus nerves. So all these things are included in this wide spectrum of musculoskeletal radiology. And as we all know that bone and joint pains, the soft tissue pains are common in our daily practice, be it from a smaller joint or the bigger joint. So the role of imaging, both diagnostic as well as intervention, comes up to give a good diagnosis and pain relief to the patient. So knowledge of basic MSK imaging helps the general practitioners, the physicians, the super specialists, and even I would say the radiologist per se, to provide appropriate treatment and to give them nice treatment options. So key imaging modalities in radiology, as we all are aware of, is the first and the foremost is the X-ray. So any patient who comes to our OPD will definitely get an X-ray done. So it's a first line imaging for any fracture, be it if a patient comes after a fall or after sudden onset pain or after a jerk, or maybe he's just doing some activity and he gets pain in any of his joints. So X-ray is the first line imaging, which we all get it done in our practice. It's such a simple, fast, cost-effective thing. And so as a family physician, it is very important to first ensure that the views which we are prescribing are correct. Why? Because the X-rays are done by the radiographers and they should be aware of uh, what the clinician is actually wanting. So ensure that the correct views are prescribed. Like example, in cases of shoulder, we prescribe an AP view and a lateral view. Or if someone wants an AP or an oblique view, so that has to be correctly mentioned. So the bony structures are important to look for fractures, dislocation, joint misalignments. Joint spaces are evaluated to rule out any arthritis, any osteophyte formation. Soft tissues are look for any swelling in the foreign body, any calcifications. So MSK ultrasound is the next modality, which is a cheaper and easily available modality, plus provides a lot of information which the MRI gives to us. So it is effective for assessment of soft tissues per se, so that the tendons, ligaments, muscles, nerves, and the adjoining soft tissue injuries, plus bony cortical outlines can be very beautifully assessed on ultrasound. So any, even the smaller erosions which we picked up on inflammatory arthritis can be looked on the MSK ultrasound. Any sort of enthesitis, and the beautiful part is like if we can all like put the color Doppler and look for the activity of inflammation. Then all sorts of lumps and bumps which we from a ganglion cyst to a lipoma. MSK ultrasound is the best. I mean, you did not go for a higher investigation, spending 8,000 rupees for a patient when you can get it done at a lower cost. And MSK ultrasound also helps us to practice pain management, giving relief to the patient in terms of his pain. And the regenerative medicine, which is in the form of PRP, growth factors, can be introduced at the right spot using ultrasound. So it is used for guiding aspirations and tissue sampling. As I said, it is the advantage is easily available, cost effective. Dynamic assessment is done. So you can, unlike MRI where the patient is static, here we can actually move the patient's hand back and forth. The joints can be assessed in different positions, and hence the diagnosis can be made. And it is easier for follow-up as well. MRI is ideal for evaluation of bone apart from ultrasound, the soft tissue injuries, ligaments, tendons, cartilage assessment. Then on MRI, the deeper areas are assessed, which are beyond the scope of ultrasound. So if someone has a suspicion of a deeper involvement, like the joint per se inside for the cartilage assessment, then MRI is the best investigation. And joint and spine imaging is done on MRI plus neurography, like the evaluation of neurovascular structures, like specifically the brachial plexus and lumbar plexus are best evaluated with MRI. The brachial plexus, though, we see on ultrasound as well, but you cannot see all the areas from the root till the cords. So MR neurography, then post-operative imaging is done in cases of MRI, like after the implant is put. So many of the patients have this doubt that like I have gotten total knee replacement done, now can I get an MRI or not? But then yes, with implants we can do MRI these days because they are usually stainless steel and non-iron implants. So the only contraindication which we should always be aware of is the pacemaker. So the pacemakers, though the cardiac companies have come up with MRI compatible pacemaker these days, but they should have a proper stamped prescription that they have a MRI compatible pacemaker, only then advise. The second is a cochlear implant. So if someone has these two, so you should check with the patient and so that they can check with their company that whether it is MRI compatible or not. And MRI is highly sensitive for bone and soft tissue tumors. CT is used for assessment of complex fractures and in cases of suspected bone tumors, the small displaced bony fragments post-trauma. Post-operative imaging is always done along with CT because there are a lot of artifacts after the implant is put, and finer bony details are done through CT. So when to do which investigation, that's the biggest puzzle which when we are sitting in the OPD. So whenever we are evaluating, so we always get that thing in our mind, whether ultrasound should be done or MRI should be done. So I think straightforward, we will look at a few cases and rather so this is our situation when we are actually this is our minds always in a doubt when we are looking at, but then after I think looking at the case studies which I will discuss, we will be I think on the right page in terms of what needs to be done next. So let's develop some case-based understanding of common MSK conditions. So MSK conditions like the bone joint imaging starts from the neck pain right till the ankle pain. So it includes from the neck till the ankle. So neck pain, shoulder pain, elbow, wrist pain, finger, thumb pains, low back pain, hip, foot and ankle, and calf pains. These are common areas which the patients usually will present with sometime or the other in the OPD. So the common conditions which we look at are the fractures, the osteoarthritis, rotator cuff tears, tendinopathy, calcific tendinitis. Sometimes the x-rays will show bone tumors, flat foot, ganglion cyst, frozen shoulders, tennis elbow, Achilles tendinitis, wrist pain, neck pain, hip pain, and pediatric patients, just suddenly playing and they develop pain. So everywhere is pain, pain, and pain. So let us start with the neck pain, with or without radiculopathy. So anytime the patient comes with, so because we are all, tech savvy these days, and most of the time, including radiologists, we just sit on the system all day. We are bound to develop neck stiffness unless proper exercises and muscle strengthening is done. Usually the patient who presents with neck pain after doing heavy gymming, so these gymmers specifically, when they come after building, like lifting heavy weights and doing all sorts of exercises, so they might present with, in the younger age group, with neck pain either due to muscle spasm or disc herniation. In elderly age group there will be spondylotic changes. So the first investigation is to look for is the x-rays of the cervical spine, which is the AP and lateral view, and it helps us to look at the curvature, quantifies the disc space, identifies any spondylotic changes. So this is the frontal and the lateral radiograph of the cervical spine, where in this case we can just see that there is straightening of the cervical spine, but there aren't any spondylotic changes in the form of osteophytes. The vertebral bodies are absolutely fine. The posterior elements look symmetrical. The disc spaces are absolutely fine. Never forget to look at this area. So this is the site where the bony cervical ribs develop. Like in this case, there is no bony cervical rib. But if you see that there is an accessory small rib coming up, this can be a cause of upper limb pain, like in cases of thoracic outlet syndrome. So it's an uncommon condition when bony cervical ribs are symptomatic, but nevertheless they can be a cause of persistent pain in the upper arm. If the patient's symptoms don't subside even after physical therapy and medications, so MRI is done to evaluate any sort of disc herniation or any cord pathology or any thing in the bony skeleton. So, like in this case, this is a young male whom I saw a few days back. So he had an acute sort of radicular pain in the right upper limb post gym workout, and he had an annular tear at C5-6 with herniation of the disc substance in the right lateral recess. So this was impinging on this C6 exiting nerve root here, which was contributing to pain. So imaging actually helps us in assessing what's happening. So we should never hesitate to get one, but then we should not be too eager to advise a higher end investigation. So always start with basic x-rays and then see if the patient is doing well. If he's not getting better, we should move towards the higher investigation. Sometimes what we see is like post viral illness or post trauma, or just maybe a minor trauma, or sometimes the patient develops some kind of weakness in the arm. So mostly after viral illness, we see these things, or after birth injuries, like for long term, which is unnoticed or ignored. So in such cases, brachial plexus injuries might be there, which may be a cause of upper limb weakness altogether. So in this case, we can see that the upper, the middle, and the lower trunks of the brachial plexus, they are bulky and edematous. And this was a base image, which actually helped us that there could be a brachial plexus pathology. And on reformatting these images, we could see that there was brachial plexitis. And the same patient, when I see, so you can see that the muscle bulk on the left side is quite good as compared to the right. So the muscles on the right side are quite attenuated as compared to the left. And there is diffuse fatty atrophy of the shoulder girdle. So here we can see the muscles beautifully around the shoulder girdle. And on the right side, this is all fat. So this was a chronic denervation myopathy in the shoulder girdle. So after neck pain, the most common area which we encounter is the shoulder pain with or without restricted movements. So whenever the patient presents with shoulder pain, so either it's coming from the cervical area or it's primarily the shoulder area which is involved. So the most common pathology being the rotator cuff tendinopathy. Uh, Next comes the adhesive capsulitis or frozen shoulder, in which there will be restricted movements both externally and posteriorly backward. There will be difficulty in comb or wearing shirt, changing clothes. Next entity is a calcific tendinitis, which presents with sudden onset excruciating pain. Next is shoulder dislocation, majorly common in the youngsters, who have lax shoulder. The ligaments are lax, loose. The joint tends to just dislocate, relocate back, and the patient presents like he says कि मुझे डर लगता है कि मेरा कंधा निकल गया है. So that is a shoulder dislocation. Next is an AC joint or a acromioclavicular joint arthritis. Another thing which we commonly see in young sports people is the labral tear. and trauma and fall is the most common, after or so those who present with fracture. So we should know when, what, and which investigation is required. So once you see a patient in the OPD, if you know it's a case of a trauma, then definitely the first investigation to be done is an X-ray. Radiographs provide most of the information. If there are no fractures, we are good and we are happy. But if the pain is not subsiding, you have a very good and a very easily available investigation, which is called an ultrasound. So never hesitate to get an ultrasound of the shoulder. It is an easily available modality. Okay, so let's have a look at the X-rays, which are the first investigation in any shoulder pathology, which helps us to assess fracture, joint space reduction, acromial spur, calcifications, and tumors. So a normal shoulder radiograph is an AP radiograph, and it should be well interpreted, being the humeral head, the neck, and the shaft. Okay, so this is the area of the glenoid, and this yellow area is the coracoid process. Okay, so this is the acromion process, and this is the distal end of clavicle, which forms the acromioclavicular joint. So after a fall, definitely if there is a fracture, this is a very obvious fracture. It's a displaced fracture, but if there are subtle fractures, you should be very careful, and clinical examination makes it all the more easy. In cases of shoulder dislocation, you will see that the shoulder, the humeral head is dislocated outside the glenoid cavity. And on the Y view, this will be confirmatory that this is an anterior or a posterior dislocation. So this is the Y view. So this is anterior part, this is posterior part. So the most of the humeral head lies on the anterior aspect, which signifies an anterior dislocation. Whenever you see a shoulder, the humeral head in the form of a light bulb, so this is called a light bulb sign. So if a patient has had a history of dislocation, this is concerning for a posterior shoulder dislocation. However, this should not always be considered a dislocation sign where there is no event of dislocation or trauma. Why? Because if the radiographer has not taken the view in a proper way, it's an internally rotated shoulder, then also this will give the similar appearance. So clinical history matching with the radiographic findings are very important. Okay, sometimes there is evidence of calcification around the bone, around the tendons, around the ligaments. So in such cases, the calcific tendinitis do present with um, excruciating pain and difficulty in movement. It's just like someone has stabbed with a knife. It's that bad. So always do an internal and external rotated view in cases of suspected calcific tendinitis. X-rays also help us to get a sense of if there is any neoplasm developing in the bone. So this is a lytic permeative destructive lesion in the metadiaphyseal region of the humerus, and there is some sort of periosteal reaction which we see. So once the X-rays are done, we find a lot of things. X-rays are normal, frozen shoulder. If the patient is having frozen shoulder, X-ray is normal, nothing. He has to be put on medications and physiotherapy. Okay, but if we find something substantial, then it has to be further supplemented with higher investigations, either MRI or ultrasound. For ultrasound being the most common one, uh, easily available modality, it is cheap, cost effective, high spatial resolution. You can see the fibers well in time. The patient is not claustrophobic in this because we are doing it in an open environment. It's a dynamic assessment and it provides quick results. The patient and doctor both are happy that the patient has gone and come back very quickly. So this is done in a dynamic motion from front, back, right, fourth, and center. So this is a beautiful modality which we will discuss now. So MRI is done again in different cases where ultrasound is not able to give a proper result, like in cases of evaluation of cartilage and labrum. So it helps us to assess the rotator cuff in detail. Then muscle status can be known, paralabral cyst in cases of labral tears, and signs of denervation can be picked up on MRI. So these are, I mean, the only, this is a widely available modality, but we should always get it done when it is required. In cases of shoulder dislocation, to assess labrum and bony Bankart, it is important. MRI is the investigation. AC joint ligaments, calcific tendinitis, arthritis, and tumor. Okay, so this is the ultrasound image of the shoulder, and we can see the supraspinatus fibers attaching at the humerus. So this is the humerus, the greater tuberosity, and this is the supraspinatus fibers. Okay, but as there is tendinopathy coming up, we can see that this tendon is swollen and edematous. Just look at, this is the normal appearance of supraspinatus, and this is the edematous supraspinatus. So this is called supraspinatus tendinosis. This is the MRI image of the supraspinatus tendinosis. So this is the muscle supraspinatus, and the tendon is coming up and joining, inserting over the humeral head. So this is the increased signal. On MRI, the tendon appears dark in color. Okay, so whenever there is inflammation, the fluid sets in and it appears bright or white in color. So this is the same image of the supraspinatus tendon being inflamed or tendinosed. So next case is on the ultrasound image. So this is the supraspinatus tendon, and we can see a clear discrete tear. It's a partial tear because it is not involving the entire width of the tendon. So this is a partial tear of the supraspinatus. Okay, and this is the near full thickness tear of the supraspinatus at the attachment. So if we can provide this information on the ultrasound, the physician is absolutely clear of what needs to be done next. So this is an example of MRI on the of partial tear, in which we can see that this is a normal tendon, but where it attaches here, we can see that there is increased fluid signal representing partial tear. And here we can see that there is a full thickness tear of the supraspinatus. All the fluid, the bright fluid here, is seeping inside the gap. And this is a case of rotator cuff or supraspinatus full thickness tear. So spinatus tendinosis, we could insert that this is a needle track and this is the supraspinatus tendon. And there was subacromial bursitis in this case. So we could actually put in a dose of steroid inside this bursa. And here we have inflated it with local anesthesia and steroid. So we know that once we have put in the needle, we are sure of where we are. Next condition is adhesive capsulitis or frozen shoulder, which is a clinical diagnosis. You really do not require an MRI to diagnose it. But why do we do an MRI or ultrasound imaging is to assess the rotator cuff tendons. Now, when we know that the rotator cuff can be assessed beautifully on ultrasound, why do we get an MRI done? Okay, so in such cases, the MRI is giving us the information that the capsule is thick and edematous, and the rotator interval here is all scarred and edematous. So that is why the movement, the motion of the patient is restricted. After a course of medications, anti-inflammatories, and reducing the inflammation around the capsule, plus physical therapy. If the patient doesn't improve, then we have an option of providing a non-invasive treatment for such patients, which are like the intraarticular injections of steroid, which helps to relieve the inflammation. And then once the inflammation has gone, then the patient can go further for his physio and rehab. So this is how we do our injections. So all the sterile precautions are maintained. Okay, so once the cleaning is done, both the probes and the target site, as we can see here, that we have marked this area from where our needle is going to go in. We have cleaned it with betadine. Our probe is being cleaned here. So we are drawing the local anesthesia. The steroid and local anesthesia run here. And now we are injecting it. So this is an ultrasound guided demonstration of glenohumeral joint injection, where we can see this is the humeral head, that's the glenoid, and we can see the needle coming in here. So that's my needle tip. We'll see it again. So if you clearly see carefully, so this is our needle entering into the joint. And when the needle has got into the joint, we are sure that our medicine has to go into the right place. So for what I do is I put in a color while I inject, and I can see that the calcium deposit around the tendon or the ligamentous structures, and there is extensive soft tissue edema. One second, I think. This is all calcification, and there is all inflammation around in the surrounding soft tissues, which has led to extensive excruciating pain to the patient. Okay, and this is another case where there was less of calcific tendinitis and there was inflammatory fluid in the subacromial bursa. So this kind of calcification can be beautifully picked up on ultrasound also, and so there are type 1, type 2, and type 3 calcifications in which we see that this is a kind of faint calcification. This is little getting matured, and this forms a shell-like thing in which the outer area is calcified, but the inner part is very liquid and very soft. So what happens is whenever there is leakage of this calcium in the soft tissues, there develops extensive inflammation around the joint, and that is called calcific tendinitis. So again, calcific tendinitis can be treated with physical therapy, with anti-inflammatory medications, but this keeps on recurring back and forth, giving a lot of pain to the patient. So as a radiologist, what we do is we put in a needle inside the calcification. So that's the calcium in the supraspinatus here. That's my needle track. And that's the image which I have shown. So that's my needle inside. So this is the needle inside the calcium, and we try to break this with normal saline. So as we all know that when we put in the saline, the pressure builds up inside the calcific core, and we can uh, actually aspirate this kind of calcium in our syringe. So this is called a calcific barbotage procedure. Yeah, sorry, my marker has just turned into, but yeah, anyways, just wanted to show here that so this is like when we are giving pulse of normal saline inside the calcification, you can see on this image, and we can see that the calcium coming inside the syringe. So this is a beautiful procedure which we do it in a pain-free environment, and the patient gets free absolutely well. Okay, so next entity is a paralabral cyst in which there is labral tear and the cystic structure comes and deposit inside the notch, compressing the neurovascular structures. So these can be aspirated and broken well. Acromioclavicular joint injuries are well picked up both on ultrasound as well as MRI, but MRI is the investigation of choice because we can actually look at uh, lot of bone marrow edema, any soft tissue. This is disruption. So this is the inferior ligament, that's the superior ligament. And here that's the superior ligament, that's the inferior ligament. And there is disruption of the ligament here, slight widening of the joint. And all these information can be given well on MRI apart from evaluation of the surrounding structures. On ultrasound, we can also see the acromioclavicular joint well, but rest of the structures, the deeper structures are little less evaluated. So we use ultrasound in AC joint for giving injections only. So take home message for shoulder pain is like X-rays are the first investigation, never to miss them. If normal, always go for dynamic ultrasound of the shoulder. MRI, if the patient doesn't improve well, most of the times you will not require it even. But then at times when you require, do not hesitate because ultimately the patient needs to be given pain relief. And ultrasound guided interventions are more specific. So definitely uh, like you should consult with your musculoskeletal radiologist when and where it is required, not always. I'm unable to move the cursor. I'm sorry. Okay, so coming to elbow pain again, the most common condition which we all encounter in the practice is kind of a tennis elbow, which is called the lateral epicondylitis. Medial epicondylitis or golfer's elbow is less commonly seen. In cases of gym goers, again, I would say distal biceps tendinitis and tear are on the rise. We've been seeing those cases very frequently these days. Triceps tendinitis, again, the gym going people, they have a lot of tendency to develop triceps tendinitis. Olecranon bursitis is another common conditions where the patient presents with elbow swelling, pain on the posterior aspect. So again, all these conditions can be seen on ultrasound very beautifully without a need to go for MRI. I'm not saying that MRI is bad or something. I'm against it. I do all modalities, but ultrasound is a cheaper, a dynamic way, and a quick results can be given side by side. The clinician can discuss what needs to be done. Underneuritis, cubital tunnel syndrome can be dynamically assessed, and the patient is happy when he spends less and gets a lot of information. So dynamic ultrasound in elbow is very important area which identifies tendinosis, partial or full thickness tear. So it helps us to assess the common extensor origin, the common flexor origin, the radial and ulnar collateral ligament injuries, the tendon, the nerves, everything. So we can see the median nerve, the uh, radial nerve, the posterior interosseous nerve, the ulnar nerve very beautifully on ultrasound. So this is an ultrasound image of common extensor origin, which is the site of lateral epicondylitis or tennis elbow. So this is the radiocapitellar joint. Okay, so that's the joint, and this is the all the extensor muscles coming up and attaching at the lateral epicondyle of humerus. Okay, and on ultrasound we can see that there is increased thickness of this tendon. So this is a case of uh, tennis elbow or lateral epicondylitis. On MRI, we can see that this extensor, so this structure which we are seeing in blue is actually this area which we see on the ultrasound. Okay, so this is coming attaching here, and wherever there is an abnormal signal, we could see that there is bright inflammation here at the insertion, which is called lateral epicondylitis. So in such cases, we can actually put in our needle and put a dose of steroid along the superficial aspect and maybe do some dry needling around the cortex, which helps us to ease like injure the soft tissue here. The blood will come up and it will form a plug. So this is a needle dynamically we have placed in here, and we inject a dose of steroid here. So in cases of partial tear, so this is a case where there is tear inside this tendon, and we can see this well on ultrasound here. So we did a PRP for this patient, and he's quite better, did almost near complete improvement after 2 sittings in this area itself. So this was case of partial tear of common extensor origin, and in cases where there is full thickness tear, there is retraction from the bony attachment. These are the candidates where we need surgical interventions. Olecranon bursitis is another condition which we evaluate on ultrasound, and we can beautifully see how this fluid has collected overlying the triceps tendon, and there is all subcutaneous edema in the overlying tissues. So never worry to never hesitate to send your patient for an MSK ultrasound. It is a very nice investigation. You actually get a lot of information. Okay, for wrist and hand, I will say ultrasound is the first investigation, even before you get an X-ray done after your clinical examination. So different pathologies, right from arthritis, from your ganglion cysts, from any swelling inside the wrist, from your nerve evaluation, what you say is a carpal tunnel syndrome, or calcific tendinitis, everything can be picked up very well on ultrasound. So this is an example, I would say, for a dorsal wrist ganglion cyst. So this was fairly sizable cyst, and we could see that that this was bulging over the skin surface and then extending inside the joint. So we could make out the neck where the cyst was communicating with the joint. So sometimes the cyst is smaller in size and it is between the two tendons. So we can evaluate that on ultrasound. We can give the volume and then decide if someone needs, like in this case, someone needs a treatment. We could just put in a needle inside, aspirate, break the wall, and inject a dose of steroid to reduce the inflammation. Even for people who want to go for a surgical excision of such lesions, ultrasound is very helpful to assess the neurovascular relationship. So like in this case, there is radial artery here and the cephalic vein here. So it's important for us to inform the treating doctor in terms of before any surgical removal is planned, or even if we are doing a ultrasound guided intervention, we are sure that we are not damaging the artery. So sometimes there is rupture of the cyst inside. You see a ganglion cyst, and suddenly the patient starts coming with pain, and the cyst has gone. So sometimes when the cyst collapse, the fluid tends to ooze out and produces inflammation. So it's important to look for where the cyst is coming, what is the appearance. So like in this case, this cyst is kind of a collapsed cyst. So it's like compressed. Okay, you can again see that there are no dark areas or black areas inside. So it's a kind of collapsed ganglion cyst presenting as pain. Next, very important entity which we encounter again in our practice is called the patient presents with pain along the extensor aspect of the thumb, and there is difficulty in abducting the thumb or elevating the thumb. So this is called a decurvent stenosynovitis, which can be again picked up well on ultrasound. So the first extensor tendon sheath which gets inflamed. So like this is the abductor pollicis longus tendon, and this is extensor pollicis brevis. So there's marked thickening of the tendon sheath. So like you see here, this is a normal tendon and there is no thickening around this tendon, but just see how tightly this tendon is bound with this inflammation. So that's called the decurvent stenosynovitis. And with ultrasound, we can clean up well. We can just put in some local anesthesia with a 26 gauge needle. And again, after going in, we can inject a dose of steroid and local anesthesia, relieving the inflammation. So in such cases, so this is after the injection where the patient was able to extend the thumb well, and this was before the injection. So he had pain at this site, and after the injection, there is no shaking of the thumb. The patient is actually able to extend it well. Okay, so wrist joint evaluation, one of the most common causes of wrist pain bilaterally is rheumatoid arthritis and the inflammatory arthritis, I would say. And wrist joint ultrasound is very essential to rule out any kind of synovitis, even mild synovitis can be assessed here. Okay, so as we see here that this is the radiocarpal joint, and we can see that the dark area is the synovial thickening and there is active inflammation, which we can see with the Doppler. And here we can see that this is the metacarpophalangeal joint, and a lot of inflammatory fluid is there between the two bones. So that's the metacarpal, and this is the proximal phalanx, and this is all inflammatory synovitis. Okay, so next is the tenosynovitis. Tenosynovitis means that there is inflammation around the tendon sheath. So this is the fourth extensor tendon, 1, 2, 3, 4, and there is inflammation and thickening around the tendon sheath. If we do ultrasound on the long axis, we can see thread-like structures. So how beautifully these structures can be seen just on sonography. And along with that, we can see that there is inflammation. And with Doppler, we can assess the vascularity also. So this was a case of rheumatoid arthritis. Companion case, I would like to share that there is even more synovitis inside the wrist joint. We can see there is increased vascularity. And if I see that whole of the collection or the thickening was just tracking and there is destruction of the metacarpal head. So this was a synovitis with destruction of the metacarpal head, and this came out tubercular. So TB, rheumatoid arthritis, they're one of the most common causes which affects our joints. And we can see there were flowing internal echoes and there was pus along with synovial thickening. At times, psoriasis, which presents as a dermatological manifestation, the patient just might come to you that he has joint pain. But if you have that thing in your mind that psoriasis being a dermatological disorder can affect the joints, then it helps us to diagnose very appropriately and easily. So like in this case, this is the flexor tendon, and there is thickening around the tendon sheath. There is increased vascularity. There is synovitis in the first metacarpophalangeal joint, and there were osteoarthritic changes in the form of uh, osteophytes around the joint. You can see here, this is a smooth bone here, smooth bone. But here we can see that there are small ossific spurs and synovial proliferation coming in the joint. So this patient had psoriasis. We can see that the fingers are stubby like sausage. There are skin patch here. There are skin patch here. There are scales here. So this patient had psoriasis, and we can see that she had all over. So she was a teacher and she never knew that she had psoriasis. She thought that she had dry skin, unfortunately. This is another case which I saw a few days back, in which we could see that there was a lot of synovitis in the wrist joint and profusely increased vascularity on Doppler. And this patient again was on levocetirizine and Avil for a long time, considering that she had eczema. And there was swelling in this joint, which we evaluated. And she had swelling around the ventral aspect of elbow, which we could see that this was insertion of the biceps tendon at the radius. So this is the radius and this is the biceps tendon inserting here. So this was all inflammation secondary to inflammatory arthritis. Next is carpal tunnel syndrome. I said it's beautifully seen. This is the median nerve. How beautifully the bulky nerve is visualized here. This is the normal nerve and this is the bulky and edematous nerve. We can have a look at the flexor retinaculum. How beautifully this is thickened. This is entrapping the nerve, and this is the whole thick nerve which is seen well on ultrasound. We can see that there is perineural scarring. So this is the nerve, and the white thing is all the fibrotic scar around the nerve. Just see how this thick nerve is ending well. Very, it's tapering here at the site of scarring. So bulky median nerve, perineural scarring. This was acute carpal tunnel syndrome, in which we can see that this is the nerve which is thick here, and suddenly it becomes normal nerve. So it showed increased vascularity, and the patient had recent viral symptoms. This was viral neuritis. Ultrasound guided hydrodissections can be done in cases where there is entrapment. So what we can do is we place the needle just superficial and deep to the nerve and inject a dose of medicines like dextrose to separate it from the plane. So we can see that the nerve is separating, and all this in the injectate or the medicine or the fluid which we are injecting is separating it from the thickened retinaculum. Okay, let's come to the lower limb quickly. So hip pain, most important investigation, what we do, the first thing is the x-rays to look for any evidence of osteoarthrosis. And in specifically young patients now post-COVID, we have seen so many cases of avascular necrosis coming up. So it's important to rule out any case of hip pain firstly on the x-ray. So avian presents with sclerosis around in the femoral heads. There are intraosseous cystic changes. There is reduction of the joint space gradually. So as it progresses further, so this is a stage 2 avian progressing to stage 3 and 4. So MRI is done to look for the status of the articular cartilage, of what status on the what stage it is, and so that the treatment can be appropriately given in terms of conservatively management with medicines like bisphosphonates, or it requires a surgical core decompression. Okay, so anytime you have a patient with low back pain, hip pain, always have a look at the sacroiliac joints, because that is one hidden area which even the radiologist miss to look at. After seeing the lumbar spine, they find that there is no disc, and they see the femoral heads, there's no marrow edema, there is no abnormality in the bones around the femur, but the sacroiliac joints are one of the most common sites which are involved in patients with hip pain and low back pain. So this is a case where there is unilateral sacroiliitis. So this is the stir image of the SI joint, and we can see bone marrow edema on both the iliac and the sacral aspect. And this is a case where we can see that there is asymmetric edema on both sides. This is a case of bilateral sacroiliitis. So if someone looks at this x-ray, mostly in my first view, we said this is normal. This was a kid, actually 11, 12-year-old, and she had limp on the right side. So owing to more of sedentary lifestyle, more indoor, there are no outdoor games, no sun basking, patients have low vitamin D altogether, and stress fractures are important sites. So this was a lucency, linear lucency, which was appreciated retrospectively after the MRI was done. So this was a case in which there was bone marrow edema in the femoral neck region for this 11-year-old kid. And this was a hypointense fracture line. And when we saw the X-ray retrospectively, we could see that, yes, because we never expected a stress fracture in such age group. But then, yes, the elderly and the youngsters both are equally prone these days. The take home points for hip, I would say x-rays are the first and the most easily available investigation, MRI investigation of choice. Never hesitate to get for hip. If there is a localized pain, go for an ultrasound. Else, I would say go for MRI. Local site pains, including muscle injuries, suspected DVT, nerve related symptoms, or superficial pain, can be mapped on ultrasound. The most common condition in the knee joint, who present with the in the OPD, are the osteoarthritis or specifically knee pain, and majorly, the younger age group, they come with the vague symptoms while they're climbing. They are climbing upstairs. They have pain. In elderly, it's, they have all age related process going on. Specifically in the footballers, the ACL injury, MCL injury is very common, and posterior knee pain, calf pain is again another area which patients present when there is a rupture of Baker's cyst and all. So X-rays are the initial investigation of choice. At least we get a sense of what the joint space looks like. Is there any joint effusion? Is there any avulsion fracture? And so forth. So the most common pattern which we all see yeah, so once the patient has done the X-ray, if not getting relieved, we definitely go for MRI just to look for we are not missing anything. And yes, so sometimes for a patient, the pain is just nagging for long. The subchondral fractures are very common these days. So subchondral insufficiency fractures are kind of a stress on a weak bone. So if there is bone marrow edema and we see the trabecular microfractures, then such patients have to be put on rest with less of weight bearing so that this heals well. So this is a fracture line, the dark one if we see here, and there is extensive edema inside the bone, which is the swelling here. Again, another case where there is extensive florid edema in the femoral condyles, and we can see that there are trabecular microfractures. So these trabecular microfractures are nothing, they're just like stress on the weak bone. In young patients, we can see osteochondral dissecans or osteochondral defects. So if we see such areas, abnormal areas, flattening of the surfaces on X-ray, we should go for MRI so that we can actually help them prevent young osteoarthritis. Young osteoarthritis is on the rise. We see so many patients attributed to sports and different dealing with arthritis at age of 28 years, and they have no other options rather to just go with physiotherapy because they have been ignored for a long time. Okay, so sometimes the osteochondral defects, they get displaced. So there was a defect here, as we saw here, but because it progressed further, there's a full thickness delamination of this defect, which has migrated inside the notch. Just see. So X-rays will be really helpful to see such cases beautifully. Cartilage changes inside along the weight-bearing surface of the femur, along the tibia, the status of meniscus, the status of ligaments can be assessed very beautifully on MRI. So this is patellofemoral osteoarthrosis. There are subchondral cystic changes or geodes which are coming up, and there is reduction of the joint space here. So this is patellofemoral osteoarthrosis. Then condyle softening, we can see that there is just focal swelling inside the cartilage and leading to pain in the knee joint. This is a focal chondral blister, which we could appreciate, which is one of the causes of pain. So this was the focal chondral blister. So advanced arthritis, when there is loss of cartilage. So in patients who have advanced arthritis, sometimes we get requisitions to get MRI done. So the idea is to actually quantify what sort of arthritis is there, like all three compartments involved or one compartment. Accordingly, they plan the surgery. Okay, so this is again where we can see that the whole cartilage has gone up. This is the normal cartilage, but this area there is no cartilage. The meniscus, the cruciate ligaments can be beautifully assessed. So this is a patient of post-chondroplasty after the cartilage repair has been performed. And then this was a follow-up scan where this newly implanted cartilage has congruated with the old cartilage, the rest of the cartilage. So this is a successful cartilage transplant patient. So this is in a young arthritis, so where there are focal cartilage loss. So that is why MRI is important to quantify what area extent the cartilage has gone so that the younger patients can be helped with chondroplasty procedures so that they do not develop arthritis further. Okay, so role of ultrasound in knee evaluation comes for evaluation of quadriceps tendon, for evaluation of patellar tendon, for any sort of screw impingements over the structures, Baker's cyst, diagnosis and injection, hemarthrosis or synovitis inside the knee joint, medial collateral ligament injury, post HCL reconstruction. We can see if there is any the the screw coming out of outside the bone, or there is any impingement on the structures, or the viscosupplementation injections can be performed in patients with advanced arthritis who do not want to go for surgeries. So this is an ultrasound of the knee joint, and this is the patellar tendon, this is the tibia, and there is bursitis in the deep infrapatellar bursa. So in such cases, if they don't improve with medications, we can actually put some medication. We can put the needle inside and inject a dose of steroid, like in this case. This is a Baker cyst demonstration on ultrasound. So as fluid appears dark on ultrasound, we can see the Baker cyst is there. If it's a big cyst, we can always put in a needle and aspirate the contents. Okay, last is the ankle pain, the foot and ankle region. Okay, before this, so sometimes knee pain, hip pain, they just present with swelling inside in the lower limb, and there can be signs of calf pain. So never, always be careful that we are not missing on DVT, which is deep venous thrombosis, and that is a red flag that one should get it evaluated if we see any signs of calf pain or the lower ankle swelling, sudden onset. Ankle pain can happen because of trauma, plantar fasciitis, Achilles tendinopathy, inflammatory arthritis, tibialis posterior tendinitis in patients with flat foot, and infection. I'm sorry, I wrote injection here, it's infection. And both MRI and ultrasound are good investigations. I do more ultrasound of foot and ankle than MRI in my practice. But then we can actually see almost many things what we see on MRI on ultrasound. Okay, so except for the bony structures, the soft tissue can be best evaluated with MRI. So with ultrasound, I'm sorry. So this is a patient of plantar fasciitis, which is one of the most common problems patients land up in our OPD. So this is the normal plantar fascia, and as it comes towards the insertion, it is quite thick and edematous. Okay, so if an ultrasound, if an MRI is done, we can evaluate the surrounding soft tissue structures. We can look at the status of other muscles and the lateral plantar nerves, along with the medial plantar nerves, if there is entrapment or what is the cause. Okay, but on ultrasound also we can see that this is the calcaneum and this is the plantar fascia, which is all thick. So this is a very much thick plantar fascia which we saw in a patient. MRI will help us to confirm if there is any coalitions. So this is a calcaneo-navicular coalition, and there is marrow edema along the attachment. We can see that the pain is not good. So this is seen well on X-rays, but if it is equivocal, we should get an MRI done to look for tarsal coalitions in cases of non-responsive ankle pain. So anteater sign on radiograph and associations with flat foot are very common in such cases. Okay. Okay, and the next is Achilles tendinopathy. So this is the Achilles tendon here, the black one, and it is coming and inserting over the calcaneum. So this is the MRI image, and here we can see there's some new bone formation which is coming up. Okay, so this is thickening of the Achilles tendon. It should look normal, jet black like this, but as it is coming and inserting here, this is fusiform thickening of the Achilles tendon. And the role of ultrasound in foot and ankle is evaluation of superficial structures like Achilles tendon, ligamentous evaluation, synovitis, and image-guided interventions. So this is a normal ultrasound appearance of Achilles tendon. All the things, see how beautiful these fibrillar the fibers are seen attaching to the calcaneum, and we can see some trace retrocalcaneal bursal fluid. So this is the retrocalcaneal bursa, this thin area. And whenever there is inflammation, so this fibrillar appearance is lost, and we can see this hazy appearance of thick tendon which we are seeing here. So this is Achilles tendinopathy. This is another case which I just saw yesterday. So this was markedly thick Achilles tendon. There are irregularity along the calcaneal attachment. There is a bony spur which is coming up. Okay, and there is retrocalcaneal bursitis. So this patient was in a lot of pain actually, and we had to inject further. So in tendon evaluation, we can look at the flexor digitorum longus tendon here, the tibialis posterior. So all these are all fibrillar structures which we see. So this was a retrocalcaneal bursal injection. So this was the Achilles tendon. So we never inject inside the tendon. So here the paratenon or the outer layer was injected, while the other needle was placed inside the bursa and injected with steroid here. This is tibialis posterior tendon. the white one, and the black thing surrounding it is all the inflammatory tenosynovitis. Okay, so these are beautiful tendinous descriptions which we are illustrations which we saw. And this was one case where there was all scar. This was all scarring from prior trauma, and there was entrapment of the tibial nerve by this scar. So this was the thick nerve and entrapped by the scar here. So not a very beautiful image, but this was scar entrapment by this of the nerve here, which was released again surgically. And we can do image guided interventions in the tendon sheath. We can just place our needle in the tendon sheath, not inside the tendon, so we know that we are not harming the tendinous structures, and injecting the dose of medicines. So it is important for all of us to know about the modalities, which modality has to be applied when. MSK ultrasounds are important tool in places which act as savior sometimes. Always look at the x-rays carefully, which is the area of concern, and then correlate. MRI, never hesitate if the patient isn't improving well. A role of contrast is one thing which I wanted to discuss. That contrast is given not in every patient. So one thing is, people think that if we give contrast, we will get more good, we will get more, we will get better images, or we will get beautiful images, or we will get more information. No. So contrast is given only when there is suspected lesion, when there is infection, there is neoplasm, benign or soft tissue osseous neoplasm, or a soft tissue neoplasm. So in that case, plus minus contrast can be if you can be requested for. And if the radiologist feels that the contrast is needed, then he can directly talk to the patient there and then. So as family practitioners, family physicians, you can all uh, educate your patients that if the radiologist, so this is one important thing which I face in my practice, that you can always ask your patient if sometimes the radiologist is calling the patient for an X-ray correlation or for an ultrasound correlation after the MRI has been done, or for an X-ray correlation after the ultrasound. So then they are cooperative in that sense. They will not charge extra, but they will definitely give you a better diagnosis. And feel free to talk to your radiologist. If you have an MSK radiologist in town, that's the best. But if not, then definitely the other person will be able to help you out. And image guided interventions play an important role in non surgical treatment. Thank you very much for your attention.
Thank you, doctor. Thank you very much. It was really enlightening.
Thank you, sir.
And this video will be available on YouTube perennially, always. There are few questions. Dr. Nirmala is asking how many steroid injections are given and how long the effect will last in different conditions.
So we do not give many steroid injections to one patient. I mean, usually I have never given more than twice in a year, though sometimes if need be, we tell the patients 3 times. But I have, like in my practice over years, I have not really given more than twice. It depends on patient to patient how the effect will go. In some patients, we have had bad response, maybe about a month, 6 weeks. So ideal time is what we tell the patient is 6 to 8 weeks. But those patients have had relief for over 15 months, 12 months, 11 months. But as treating doctors or diagnostic people, we really don't give them very high hopes of long-term relief, so that if need be, we can give a second dose. But then, yes, you can always say about 6 to 8 weeks as a standard time, and then let's see how his body heals. Because after injections, the physical therapy is very important, which needs to be appropriately done. So sometimes patient just gets an injection and then they will not do any sort of physiotherapy. So that defeats the purpose of reducing the pain. Please explain in MRI of lumbar spine, mild diffuse disc. So there's a question from Dr. Irani. So he says that if MRI report says that there are mild diffuse disc bulge with indentation of the exiting nerve roots at these levels, does the patient require surgery? No, I don't think so. That we all have disc bulges, even in the younger population, because of our lifestyle and all. But then, if yes, if the patient has significant canal stenosis, if the patient has disc herniation, which is compromising the canal, which is causing mark compression on the nerve root, in those cases, two things can be done. Firstly, Physical therapy is the most important thing to reduce the pain. Physical therapy in the terms of machine physiotherapy. Once the pain starts to go away, one can do strengthening of the muscles. If not, pain blocks can be given, the nerve blocks. And if not improving again, then definitely surgery is the last option. Next question is some books for better understanding. I think a lot of data is available on YouTube these days, and because it's a whole bunch of things. I haven't covered everything, but I just wanted to cover those topics which we commonly encounter in the daily practice. ACL tear is not seen on X-ray. Uh, Dr. Aarti is saying, okay, we'll call you to Gurgaon, ma'am. Okay, I think I've answered all the questions mostly.
Thank you very much, doctor.
Thank you so much,
Our
sir.
audience have loved you, and more will be seeing on video.
Surely,
And
definitely.
we may disturb you maybe in a year's time for updates on this modality of imaging.
Thank you so much, sir. I think
Thank
my
you very
request will be that you can just try with one joint for wrist, for elbow and shoulder. Definitely go for ultrasound in your because it will be easily done by all the radiologists around. Foot and ankle needs little more training, but then don't hesitate for Achilles tendon, plantar fascia. These are common conditions which we see. For any local site pain, you will get more information than any other thing. So my request to each one of you, don't hesitate, just go on.
Thank you very much, sir.
Thank you, Emma, sir.
Thank you. Bye.
Bye.